I'm going to really focus on three main advances. First of all, a developmental focus. So many of you will be aware that in the past, even when I was trained, we were taught that you cannot diagnose personality disorder in young people, and that you have to wait until 18 to do it. That, I think, is one of the biggest advances that has happened in the last 10 years. The second biggest advance, I think, is the move, as Amelia explained, to the dimensional model, the alternative model for personality disorder diagnosis. So nosological reform, changing the way that we diagnose personality disorder. And then the third one that I'll just touch on briefly, because I'll be running out of time, but I also think this is a very important recent advance, is to start thinking about common factors, not only common factors in psychopathology, but also common factors in treatment. So really the movement to identify common factors in psychopathology and to map our treatments onto those common factors. And so I'll be talking about mentalizing as one of those common factors. So you'll see that all three of these advances tie together in the end to hopefully give you a coherent story as to at least my view on where personality disorder research currently stands, and also where we might be going. So just a little bit on where have we been. I'm going to talk about the work, obviously, through my own lens and my own research, but just to be aware that there are many other people that contribute to this research agenda across the world. But I'm going to focus a lot on my own work because I'm most familiar with that. This was not my own paper. This was Andrew Channon's paper that he published in 2008. And he titled the paper Personality Disorder in Adolescents, the Diagnosis That Dare Not Speak Its Name. It brings up ideas of Harry Potter and Voldemort, that you can't name it. It's so awful that you can't name it. And he was making the case in 2008 that we really need to turn our focus to personality disorder in young people. At the time, very few people have had interest in this topic. Paulina Kernberg, who was Otto Kernberg's wife, she wrote about this. She published this book around that same time. I think it was 2004. Joel Paris in Canada was working on the topic, or beginning to work on the topic a little bit. He published this in 2005. And Drew Weston was another American psychiatrist who was publishing and thinking about personality disorder diagnosis in young people. There was also Ephraim Bleiberg, whom I started working with around 2004, who published a book around that time on treating personality disorder in young people. There were two special issues published at the time. The one was in the Canadian Child and Adolescent Psychiatry Review, and the other one was in Development and Psychopathology in 2005. Mark Lenzenweger and Dante Cacchetti put together a bunch of papers for the first time in an American journal, a US journal, that started shining a light on this topic. But very few people at the time was studying this. And the reason people were not studying this was because of these 5 basic ideas or beliefs that was very prevalent at the time. The first was that our psychiatric nomenclature, so the DSM and the ICD-11, or ICD-10 at the time, DSM-4 at the time, did not allow for diagnosis of adolescence. The second belief was that certain features of personality disorder are normative. So, the idea that all adolescents are a bit borderline and that they kind of will grow out of it, and that this is not symptomatic of personality disturbance. The third one was that we can explain personality disorder with traditional axis 1 disorders, things like ADHD, depression, anxiety, that we didn't really need a personality disorder label to explain what's going on with a young person. We can just rely on these old Axis 1 disorders. The fourth idea was that adolescent personalities are still developing, and therefore it would be they're unstable. They don't have stable personalities, and we can't diagnose personality disorder because personality is not yet stable. And then finally, and this one is the one that clinicians would cite as the most important reason for not diagnosing, is because of this reputation that personality disorder has as a long-lasting, treatment-resistant, and unpopular to treat diagnosis. And because of these beliefs that it is long-lasting, treatment-resistant, and unpopular to treat, it would be stigmatizing to label an adolescent with personality disorder. And so many clinicians would meet a 15-year-old or a 16-year-old, and they would think that this young person feels very borderline or feels as if they may have personality disorder, but they would tell their colleagues, I think it's personality disorder, but they wouldn't write it down in the chart because they would feel that that would stigmatize the young person. So around this time, when all this beliefs were going on, I was working at the Menninger Clinic, which is an inpatient setting in the US that is known for studying personality disorder. And at the time, they did have an adolescent treatment program, and I was the director of research for the adolescent treatment program. And at the time, about a third of young people coming into the unit met full criteria for BPD. And so we were, thinking about this. How is it possible that nobody believes in this diagnosis in young people, yet a third of the people that come into the unit, the young people that meet full criteria for BPD? And so we began to look into this topic ourselves. And this was one of the first papers that we published in 2009 with Catherine Romero. We reviewed papers from 1940 to 2006. And we found a total of 58 studies at that time, say about until 2008. And we basically did a comparison between the data available on young people with BPD and the data available on adults with BPD across these areas: diagnostic criteria, diagnostic instruments, diagnostic measures, prevalence, comorbid disorders, cause, environmental risk factors, neurocognitive, biological correlates, and genetic factors. And across all of these domains, what we found in these early studies, the 58 studies, what was that adolescent BPD was very similar to adult BPD in terms of all of these characteristics. So that made us confident that perhaps the downward extension of BPD to adolescents may not be such a weird thing to do. And it may be, in fact, important to do if we want to prevent and start with early intervention. If there are developmentalists in the room, you will know that the sooner we start intervention, the sooner we can get a young person back on track of the typical normative developmental pathway. The longer we wait, the bigger the distance becomes between the normative pathway and the atypical pathway, and the work is so much more and so much more time, takes so much longer to get a young person back onto a typical trajectory. So we felt that this is worth looking into for those clinical reasons. At the time, we developed a protocol for studying young people. I was working closely and continue to work closely with Peter Fonagy. So the organizing framework for this assessment protocol was mentalization. And this was because Peter Fonagy had written from the 1990s onwards, he had put forward the argument that mentalizing deficits lie at the core of personality pathology. And so we organized our battery of measures around assessing personality function, family function, mentalizing capacity, emotion regulation capacity, and so forth, attachment as security. This assessment protocol we still use in my clinic today, which is an outpatient clinic. So we continue to collect the data. The measures have changed because the field has changed, but we still collect data on these basic constructs. And this is a sort of basic model that guided our research and continued to some degree to guide our research, that something in the early caregiving environment may go wrong that affects attachment security. It also affects a parent's capacity to be psychologically present for a young person, for a baby, for an infant, for a toddler, for an elementary school age child, for a high schooler. So something in that disrupts the attachment relationship makes it hard for the parent to mentalize the child. That affects the child's development of self as well as mentalizing capacity. That has a knock-on effect of emotion regulation, and a whole host of psychopathology can then develop. This was a very basic model that we published in 2008. Since then, the model has expanded, has become more complicated. And I will talk a little bit about that later on. So at that time, so we've collected data, a lot of data, starting 2009 when we published this protocol. What I want to focus on in more detail is a paper that I presented at the North American Society for the Study of Personality Disorder in Boston in 2013. Now, those of you that keep up with American, events, that was also the year that there was a big terrorist attack in Boston. We continued on with the conference, which happened at the same week. So it was a very, it's very clear in our minds, this conference. From a research standpoint, what we presented from my lab was 3 cohorts of BPD data. And we did a factor analysis. Here's the 3 cohorts. We did an adult clinical cohort of 747. We did a child community cohort of more than 6,000 kids, and an adolescent community cohort in Houston of 1,000 kids. We actually replicated this then also in the inpatient sample of adolescents at the Menninger Clinic. What we did was a factor analysis across all 3 of these samples using different appropriate measures for measuring BPD in adults, the SCID-2, in young people, the CI-BPD, which is an interview-based measure, and the BPFSC, which is a self-report measure for young people. And we used item response theory analysis. What we found was that the items, the criteria, the 9 criteria of BPD behaved very similarly across adults, community kids as well. And these were kids from the UK, United Kingdom. These were kids from America. No matter whether we used self-report, interview-based, an adult measure, a child measure, the items behaved similarly across these cohorts. And importantly, we found evidence for a unidimensional factor structure. This was important because, remember, at the time, people didn't think that BPD existed in young people. And so showing that it hangs together in a factor analysis as a coherent syndrome was very important for us at the time. You know, if you have a runny nose and you're coughing and your body hurts, you will think to yourself, okay, those are 3 symptoms of a flu, and they should hang together. If you have a pain in your big toe, that item will not hang together with the rest of those other 3 items in explaining the illness of the flu. So for us, the fact that these items, these symptoms hang together in one coherent unidimensional factor structure, they all loaded onto one dimension, meant to us that, you know, this is some evidence that BPD exists in young people in the same way that it exists in adults. Now, other people were at the time publishing longitudinal data. This is one famous study, the Children in the Community study. It tracked 800 kids from age 9 to age 22. And what this study showed was that there is a normative increase in borderline traits over the adolescent period. But most young people show a normative decline as they age into young adulthood. What this data also showed was that there is a percentage of young people that get stuck. They don't show a normative decline in borderline symptoms. Now, all of these kids will not meet criteria for BPD going forward, because remember, if we ask the criteria for BPD, emotion dysregulation, anger, identity disturbance, abandonment fears, relationship problems, impulsivity. If we ask those questions, they may also indicate other psychopathology like substance use disorder, impulsive risk-taking behavior, antisocial behavior. So it's not that all these kids meet criteria for BPD, but there is a subset of kids, and it's a large percentage, a fifth of kids, that tend to kind of get stuck and they don't show this normative decline. So the idea that all kids are a bit borderline and all kids show a normative decline started to be challenged by this data. This was replicated by research for Barbara de Klerk in Belgium. Also, Aidan Wright reanalyzed data from the Pittsburgh Girls study, found the same thing, that by and large, we see a normative decline in these maladaptive traits, but there are kids that show upward trajectories as well, that they don't show and follow this normative decline. The other big finding that started to emerge, around the 2010s, was that BPD is as stable in adolescence as it is in adulthood. And what we're talking about is really rank order stability. So even though at the mean level, we see this mean level increase over time, your position in relation to other people, the rank that you have compared to your peers, stays stable. Whether you are measuring this actually in 8-year-olds or 7-year-olds, but also 12-year-olds, 13-year-olds, 22-year-olds, 46-year-olds. If you are someone who tends to be more emotional, more impulsive, compared to your peers, you always remain a little bit more impulsive. And the rank order stability coefficient is pretty high, 40 to 65. This is just one study by Marina Bournavalova, but this has been replicated many, many times. As I said, the CIC study, children in the community, replicated it with 0.7 to 0.4 to 0.7 coefficients. The Minnesota twin study replicated it for 53 to 73. Andrew Channon's work in Australia replicated it in a clinical sample at about 0.54. And the take-home message is that basically personality disorder traits are as stable as they are in young people as they are in adults. So this idea that they become more stable, it is not true. We do see a little bit of an improvement in stability, but it's not clinically significant. Prevalence rate also started to be published, showing that it is indeed similar to adults. 11% for outpatients, 33% to 50% for inpatients. Epidemiological studies started showing a 3%, 1%, 2%, anything between 1% and 3% for adolescents with BPD, which is that's exactly the prevalence rate for BPD in adults. Importantly, studies have started showing, and this is a very recent study, but these studies started coming out in 2010. When you do follow up of young people with BPD, so the dark blue bar, young people with very high BPD symptoms at age 12 compared to 12-year-olds who have low BPD symptoms. If you follow them up for 10 years, this is a big sample of over 2,000 young people. If you follow them up for 10 years, the dark blue lines show much poorer outcomes in mental health, in functional outcomes, and in even adolescent victimization than the light blue lines. So having borderline traits, high borderline traits at age 12, put young people at real risk for poor outcomes going forward. Importantly, these symptoms for assessing BPD wasn't the 9 criteria for BPD. They were symptoms that were chosen for their interpersonal and intrapersonal characteristics. It's really the core features of BPD. It turns out now later years, and I'll talk about that more. But it's really these core features of interpersonal and intrapersonal, interpersonal and self problems, impairment, that were assessed at age 12 that showed these sort of poor outcomes for young people. Importantly, in the next step of their regression, this is the regression analysis of beta coefficients. When they did in a second step, they controlled for axis 1 put anxiety, depression, ADHD, and so forth. Most of the predictive validity of BPD symptoms held. That tells us that there is something special that BPD adds to the variance explained in the dependent variable in the outcome. It's not just axis 1. It is actually something extra that BPD brings to the table to predict poor outcome. So that was an important finding. There's been several other of these findings. We published a bunch of them. This is a review that Stephanie Stepp published in 2016 of prospective follow-up studies that showed that internalizing and externalizing problems, so with internalizing we mean depression and anxiety, distress disorders. With externalizing we mean ADHD, conduct disorder, risk-taking behavior, antisocial behavior, impulsivity. So internalizing and externalizing disorders precede BPD, and then they start co-developing with BPD in adolescence, so that you have this sort of mixture of internalizing, externalizing, and BPD in adolescence going forward. But that BPD comes out, crystallizes as its own disorder, regardless of internalizing and externalizing. Another way to look at this is to compare groups of young people with BPD in the black, psychiatric controls. So these are inpatients, but they don't meet criteria for BPD, but they're very ill young people. They're ill enough to be admitted to inpatient ward. And these are healthy controls in the community. And what you can see for a range of correlates, this is mentalizing capacity, hypermentalizing, and implicit mentalizing. Young people are doing worse in doing well in implicit mentalizing, and they do more hypermentalizing, which is bad for them, than the healthy controls and the psychiatric inpatients. So again, yes, psychiatric inpatients do have problems in mentalizing, but the BPD patients have more of it. Same with experiential avoidance. Experiential avoidance, as some of you may know, is the target of treatment in acceptance and commitment therapy. So here the borderline kids show the same problems. Also emotion dysregulation for all of the subscales, but also the total score. The borderline kids show the most problems, and there's significant differences between all three groups. Another way of looking at this is when you do a regression analysis with some kind of outcome, and you put anxiety, depression, internalizing and externalizing in the first step of your regression analysis, and BPD in your second step of your regression analysis. And you then see, does BPD make incremental, does it have incremental value? Does it explain more of the variance in the dependent variable if you add BPD? And our studies for suicidal outcomes have shown BPD does improve our predictive validity, as did Andrew Channon for general functioning. The other big finding at the time was that BPD is as treatable in adolescence as it is in adulthood. This is just some of the trials that were done, RCTs that were done. We published a review of this in 2015 in Journal of Child Psychopathology and Journal of Child Psychiatry and Psychology. So you can see it's sort of MBT, DBT, emotion regulation therapy, and cognitive analytic therapy. Those were the big trials that were going on. Since then, there's been more trials. But the point was, at the time, people started showing that BPD can be treated in young people. So that therapeutic nihilism that made clinicians not want to diagnose it because it can't be treated, that idea started to be challenged. In our Menninger sample, we followed up a very large sample of young people, 556 over an 18-month period. So this is a naturalistic follow-up study. And we showed, like in adults, they show a reduction as a function of inpatient treatment. By the time they get discharged, they almost below clinical cutoff. By 6 months, they're below clinical cutoff, and they sustain those gains. Again, challenging therapeutic nihilism. So, as you can see here, Amelia talked about this book that Jennifer Tackett and I published in 2013. There we showed all of the research that has taken place and this sort of exponential increase in published studies on borderline personality disorder in young people. This also allowed us to build this model about the development of BPD in young people. that BPD lives on top of internalizing and externalizing problems in young people. So the typical trajectory would be a young person that starts having problems in anxiety and depression pre-adolescent. When they come into adolescence, they start developing BPD problems. Internalizing and externalizing remain. They still struggle with that, but on top of that, something extra begins to emerge. Another kind of problem begins to emerge on top of that. Now, this model is a model that we've adapted from Caspi's model that they published in 2014 on the P factor. I'm not going to go into too much detail about that, but what the P factor means is a severity spectrum. It's called the psychopathology factor, P factor. And it's a severity spectrum, and it organizes psychopathology along this severity spectrum to put internalizing at the bottom, externalizing at the bottom of severity. It's kind of neurotic disorders in the old Kernberg model, and then schizophrenia and psychotic disorders at the top of the P factor, psychotic disorders. All we did in building this model was put personality disorder on the way to thought disorder. This doesn't mean that all people with externalizing and internalizing develop BPD and then develop schizophrenia, not at all. It just means that if we organize psychopathology along this P factor, this is where you will find these types of psychopathology. So also, of course, that from a developmental point of view, we first see internalizing and externalizing emerge, and in adolescence, we see personality pathology begin to emerge. So all of this research at the time allowed us to say that these previous beliefs were really myths. Psychiatric nomenclature, it turns out, does allow for the diagnosis. Actually, since DSM-3, you could diagnose it. ICD-10, you could diagnose it well. It's just that clinicians were reluctant to do it. While certain features of PD are normative, some young people grow out of it. And the features are just symptomatic, and the features are symptomatic of personality disturbance. The symptoms of PD are not better explained by traditional Axis 1. Personality is relatively stable across development, and there are reliable tools to diagnose PD. So a lot of people published a lot of psychometric studies on these tools to diagnose PD in adolescents. Personality challenges do improve in response to treatment. And in addition, people with lived experience, people with BPD, started speaking out and asking for early intervention and prevention. So we started at the time publishing papers like this in 2015. If it looks like a duck and quacks like a duck, then it is a duck. So evaluating the validity of borderline personality disorder in adolescents. Published a paper called Bridging the Gap, the assessment and treatment of adolescent personality disorder in routine clinical care, acknowledging that even though the research was taking place, people on the frontline, clinicians, were not really using the research. And this is the practitioner review Peter Fonagy and I published in JCPP in 2015, trying to give a guidance to clinical practice for early assessment and diagnosis and treatment for BPD. Andrew Channon published a similar paper, 2015, Borderline Personality Disorder in Young People, Are We There Yet? Is this translation of the research taking place? And then Michael Kers, Andrew published a paper also in a European journal with the same take-home message. Giles Newton-House, Leanna Clark, Andrew Channon published a paper in The Lancet acknowledging that BPD develops in adolescence. In 2017, we put out a position paper in World Psychiatry with the title Prevention and Early Intervention for Borderline Personality Disorder, a novel public health priority. Really trying to encourage people to begin taking this up in order to prevent suffering and just this hard work that lies ahead if we can't bring people earlier back to a normal trajectory. All right. So the other thing that happened at this conference in 2013, however, and this was an important challenge for me at the time. There were two people in the audience, Leanna Clark and Aidan Wright, and they said to me, you know, it's okay if you show that BPD hangs together as a unidimensional factor, but the real test for whether that's true is if you put a lot of other personality disorder symptoms into a factor analysis to see if BPD still hangs together. as a unique disorder, as a discrete disorder. And the reason they challenged me on this is because there's such high comorbidity for personality disorder. If you meet criteria for BPD, you probably meet criteria for 2 or 3 other personality disorders as well. If you meet criteria for BPD, you probably also meet criteria for anxiety and depression and substance use disorder, as we already discussed. So the challenge that those 2 researchers gave me was, you need to demonstrate that BPD still hangs together if other symptoms are put in the same factor analysis. So that's what we did, Leanna Clark, myself, and Aidan Wright. We took the big Menninger data, the adult data, and we did a factor analysis. We include 6 of the personality disorders in there because by that time, the alternative model, the new model for personality disorders, was published not in the main section of the DSM, but in an alternative section of the DSM. And those were the 6 disorders that were retained. We put those 6 disorders' symptoms into a factor analysis, and this is essentially what happens. All of the symptoms of BPD that's supposed to load onto a borderline factor does not do that. All of the symptoms of avoidant that's supposed to load onto avoidant doesn't do that. All of the symptoms of OCPD that's supposed to load onto OCPD doesn't do that, and so forth and so forth. What happens instead is cross-loading. These disorders do not exist as discrete disorders. They simply don't. The other important thing that this data showed was that BPD, if you look here, you see that the factor loading is 78. BPD almost exclusively loaded onto the general factor. The other disorders, when we ran a bifactor model, loaded onto their own respective factors. Here, Aidan Wright reanalyzed other data, and instead of putting a category in there like avoidant or narcissism or antisocial, he put the 5 maladaptive trait domains in there, and I'll come back to that. What it shows is that BPD is unique compared to the other 10 psychiatric personality disorders. It loads onto the general factor of personality pathology, not on its own specific factor. The other flavors of personality disorder does load onto their own respective factors, and I'm going to come back to that in a moment. So what we started learning around 2015 was that personality pathology acts in the same way as intelligence. We all think of ourselves on a bell curve of intelligence, having an IQ, an intelligence quotient. It's the general factor, the G factor of intelligence, but that there are specific factors too. All of these load onto the G factor, and these items load onto their own specific factors. So we can measure this if we want to have the flavor of intelligence difficulties, strengths and weaknesses in intelligence issues, but we all lie on a general factor of intelligence. Same thing with personality is what we now discovered. And this was the model that was published in section 3 of the DSM. So if you do have a DSM, go and look at your section 3 of your DSM. You will see the alternative model for personality disorder in there. The reason it wasn't in section 2, which is the main section of the DSM, was because at the time, 2013, the DSM-5 workgroup proposed the alternative model, the dimensional model, and I'll explain what that means. They proposed that dimensional model, but the American Psychiatric Association did not feel comfortable letting go of the 10 discrete categorical disorders, even though, as we saw, they don't really exist like that in the data. They felt that the clinical community wasn't ready to transition, and that more research was needed to help the clinical community transition. So let's talk about this new better conceptualization that was ultimately not accepted in section 2, but has been in section 3 for the last 10 years, 2013 to 2023. What does it look like? It tries to distill the common features, the G factor of personality pathology. Now, as I said earlier, BPD is a good proxy for that, but it's not a perfect proxy for that. We can do better for that because BPD has all of these connotations with the borderline construct. So instead, what are we looking at? We are looking at criterion A of the alternative model for personality disorder in section 3, and it's called the level of personality functioning. This is then what is defined as the core common features of all personality pathology, regardless of its flavor, regardless of its manifestation. All right, so let's talk about where we are now with this. I'm going to first introduce just briefly criterion A to you, because this is the general factor. Level of personality functioning, 0 to 4. What is the core feature of personality functioning? It's maladaptive self and interpersonal functioning. There are two aspects of self that we assess, identity and self-direction. And there are two aspects for interpersonal functioning, empathy and intimacy. Okay, so just park that in the back of your mind for a little bit. I'm going to move on to criterion B. Criterion B gives us the flavor, the manifestation of the personality pathology. And this, if you know personality disorder research, you will know that criterion B comes out of a tradition of studying personality that's called personality psychopathology spectrum approach. What it says, and here are the 5 trait domains. I'll just go through them briefly. There are 5 trait domains. They map onto the big 5. So if there are any basic personality disorder researchers in the room, or many of you would have learned about the big 5, it spells ocean when you think about them. The 5 maladaptive trait domains were developed to map onto the big 5. So negative affectivity is the severe end of neuroticism. Detachment is the severe end of extroversion, the maladaptive end of extroversion. Opposite. Antagonism is the severe end of disagreeableness. Disinhibition is the opposite and severe end of conscientiousness. And psychoticism is the severe end of openness. So that's how these 5 trait domains were conceptualized. Developmentally, these 5 trait domains live on top of temperamental traits. So when we come into the world, we are born according to these approach and avoidance dimensions. Some babies are smiley babies. They have a lot of positive emotionality. Other babies are avoidance babies. They have a lot of negative emotionality. And the third dimension that researchers in temperament with infants identified is effortful control, conscientiousness. So these basic temperamental traits, when you are born, that's genetically loaded, interact with the early caregiving environment or early context, and your personality traits develop. And as we know, there are 5 of them, most notably extroversion, that maps onto positive emotionality, neuroticism, that maps onto negative emotionality, conscientiousness, that maps onto effortful control. And then the 2 others. I concentrate on these 2 for a reason that you will see shortly. These interact with the environment some more, and at the end of that, you have your personality. But that begins to emerge now in adolescence and adulthood. Now, when we factor analyze those temperamental traits. Oh, I should have said, the other thing that this is what I already said, the big 5 then was just used to develop the 5 maladaptive trait domains. So that positive emotionality is most extreme variant is negative affectivity, negative emotionality, detachment, effortful control, disinhibition, and just you can see it mapping onto the big 5 as I explained before. Now, when you factor analyze temperamental traits in infants, or in preschoolers, or in elementary school age children, you get 2 dimensions, internalizing and externalizing, avoidance and approach. If you factor analyze criterion B traits or the big 5, you get internalizing and externalizing, those same dimensions. So what this tells us is that these traits are really continuous aspects of our personality functioning that are there from day one, from the day that we are born. Now, why, if that is true, would we not diagnose personality disorder in an 8-year-old? Let's look at that again. If we take a child who's very high on negative affectivity, a child who's very high on detachment, a child who's very high on disinhibition, and the child is 7 or 8, why do we not diagnose personality disorder? I think all clinicians would feel uncomfortable with that. So why do we wait until adolescence to feel a bit more comfortable with this? Something happens in adolescence that did not happen before. And that is that we become a person. We develop an identity, we consolidate an identity, we develop an integrated sense of self. Sense of self I put in red because I'm going to come back to sense of self. And so that brings us to criterion A. The criterion A is what happens in adolescence. Criterion B is always there from the beginning, but it doesn't mean that we have personality disorder if we're just impulsive or if we're very emotional. It may mean a lot of different things if we're emotional, impulsive, or reactive. We need to look at criterion A to know whether a person really has personality disorder or not. So we're going to look at identity, self-direction, empathy, and intimacy. And I want to give you the other big advancement of criterion A is that we score it from 0 to 4. 0 being healthy personality functioning, 1 being, few difficulties in personality functioning, a few difficulties in identity, self-direction, empathy, and intimacy. 2 being where you have significant difficulties, probably meeting clinical threshold. 3, significant difficulties, you really do need to address these problems. And 4 being very severely impaired, a person that may be very dysfunctional by that time, no relationships, no job, can't function properly in a work or a personal environment. So we have these 5 levels of personality functioning, and I think it makes personality pathology probably the only one that includes in the description, the diagnostic criteria, a healthy variant. That means that we are really fully dimensional in understanding personality pathology. As I will say later, I think it's a much more destigmatizing way to think about personality functioning, that we all can move up and down in ourselves. This scale, I can have bad personality days where I'm more grumpy, where I'm more irritable, when I snap at people, when I kind of lose sense of what were my plans, what did I really want to achieve by, coming here, doing this job. We can all have days that we move up and down this continuum. Of course, if you have more days on a 2 and a 3 and a 4, you have personality disorder. If you keep it to a 0 and a 1, you are healthy in your personality functioning. So here's what a healthy personality then looks like. A person with ongoing awareness of unique self and boundaries, consistent self-regulated positive self-esteem, accurate self-appraisal, experience, tolerates, regulates a range of emotions. In terms of self-direction, reasonable goals, realistic assessment of capacities, appropriate standards of behavior, fulfillment in multiple realms, can reflect on and construct meaning of internal experience, can understand others' experience and motivations in terms of empathy, can mentalize, in other words, can comprehend and appreciate others' perspectives, aware of effect on own actions or others. So really mentalizing capacity. Intimacy, can maintain multiple satisfying, enduring relationships, desires and engages in a number of caring, close reciprocal relationships, strives for cooperation and mutual benefit, flexibly responds to others. So this is a healthy personality. I think you can all agree that we don't function at this level all of the time. All of us have days that we divert from this. And, I invite you to go and look at the levels of personality functioning in your DSM-5, section 3, 4, 1, 2, 3, and 4. Now, this is not an old idea that this is what personality really is. I think we got a little bit sidetracked with trait psychology in forgetting that originally personality was defined as an intrapsychic system, something that happens in the mind that we use to understand and manage the self. William James talked about an I, an intuitive emotional experience sense of self, and a me, that's a result of a self-reflective process, a mentalizing process, something that looks from the outside in to make sense of who I am. Freud talked about the ego and the id. The ego, of course, reflecting back on the id. The Mead from social psychology talked about the social world, an audience, real or imagined, that facilitates self-regulation, invoking the idea that humans can look upon themselves from the outside in to regulate the self. Carl Rogers talked about a healthy personality as a person in a fluid process, not fixed and static entity, a flowing river of change, not a block of solid material, a continually changing constellation of potentialities, not a fixed quantity of traits. He said, it seems that gradually, painfully, the individual explores what is behind the masks he presents to the world, and even behind the masks with which he has been deceiving himself. Thus, on an increasing degree, he becomes himself, not a facade of conformity to others, not a cynical denial of all feeling, not a front of intellectual rationality, but a living, breathing, feeling, fluctuating process. In short, he becomes a person. Amelia talked earlier that I titled that paper, What It Means to Be Human. Criterion A is what it means to be human. It is this process that we have a mind. We are not just our traits. We are not just our dispositions that come from our genes. We do something with our traits. And we have a choice. We have agency as human beings. This is what makes us different from animals. Now, more recently, Dan McAdams has put forward his theory of personality that integrates all of these ideas in a very, very nice model. He doesn't study pathology, but I think it's a very, very useful model for us to understand why pathology emerges. So just as we've been saying, people come into the world with dispositional traits at, 0. They keep having these dispositional traits right through their lives. At age 5 to 7, however, something different emerges in terms of personality functioning, our goals and our values. So you can have, and there's actually research showing that, you can have two people who are equally conscientious, impulsive, and reactive, but one becomes a criminal and the other becomes a leader. So the fact that we have the similar levels of traits, that's not what makes us different. It is what we do with those traits in terms of our goals and values that add to our personality functioning. Of course, most importantly for our purposes, what happens in adolescence is that the self as author begins to emerge. So self as actor, self as agent, and then self as author. This is when we have the metacognitive capacity. Something happens in the mind that helps us reflect on who we are, who we want to be, begin to integrate all of these pieces of the puzzle into coherent narrative of self. So that's really when we can see when personality disorder onsets, because something is going wrong in the capacity of the person to put the pieces of the puzzle together as to who they are. The sense of self is not binding. I think it is Yeats who said, the center does not hold. There's not an internal center that is beginning to hold, that can be a rudder to steer this person forward. And that's what we need to address then in therapy. So very important then to remember that the self is representational. The self doesn't really exist. Guilford and Miller says it's a fiction. David Hume talked about the perception as a self arising from meaningful associations between each impression or experience in consciousness. And it is not grounded in a real or actual self. It is constructed through memories, that self-continuity emerges, John Locke said. So there are all these aspects of a sense of self, the narrative self that we look at: temporal coherence, the order of things that we organized; causal coherence, how did one thing lead to another in our lives; thematic coherence, the similarity between different things that hang together to create a coherent sense of self; and importantly, awareness of the stories that we are telling about ourselves, drawing on these stories to understand the kind of person that we are. So this metacognitive mentalizing capacity. How do we develop this sense of self? Peter Fonagy put forward this model already in 2002. As we've been discussing, we come into the world with a physical self, dispositions. We are born with certain dispositions, but we can't have access to them. We don't have the metacognitive capacity to do that. So what happens is instead, our caregivers give us feedback on what we are feeling, what we are thinking, in a non-intrusive way. We call that marked mirroring, or parental reflective function, or parental mentalizing. If this works well, over time, through the serve and return and the serve and return with our caregivers, we develop a sense of self. And that brings us to the psychological self. Understanding of self externally and internally, a psychological self, a representation of self, a narrative of self. All right. So Eric talked then about the ego, that defines ego identity as the accrued confidence that one's ability to maintain inner sameness and continuity is matched by the sameness and continuity of one's meaning for others. So in other words, if you keep getting information from the outside that doesn't match your internal experience, you are going to struggle in your personality functioning. And I want to add here that I've been thinking a lot about this. We need to write a paper to put this all together, but I think we are underestimating the role of society in this for minorities, and what that does to a person's capacity to be able to make sense of themselves. So summary, humans contribute to an active and continuous process of reflection and interpretation of themselves and others. The capacity for this reflective process onsets in adult form in adolescence and facilitates consolidation of identity and adult role function, love and work. If disrupted, personality pathology criterion A dysfunction ensue. Criterion A can account for the onset of personality in adolescence, while criterion B provides a useful descriptive account of the continuous aspects of personality functioning over time. While criterion B maladaptive traits provide important descriptive nuance to the manifestations of personality pathology, maladaptive criterion A function is conditional to the diagnosis. I'm going to keep my eye on the time. So if we come back to this model now, what we can do instead of BPD, we can put criterion A. And remember, in the model, externalizing and externalizing is the same as criterion B. So if we put this now in the model, it looks like this. Internalizing, externalizing develops. It continues to be there. On top of that, criterion A develops, and it's on this severity spectrum on the way to psychosis. All right, I'm going to briefly go through this. I'm not going to get into the details of the studies, but I wanted to put down the studies so that you know there's empirical evidence for all of this thinking. If you want to have copies of these papers, please, Emilia can write to me and I can send you copies if you want to go into the details of it. But here are the take-home messages starting to build the empirical basis of all of these ideas. Traits, criterion B, affects social functioning. This is pre-adolescent. It affects social behavior and gets social feedback. Over time, affects self-functioning 10 years later after the traits. So again, the message that we have dispositional traits that interact with the environment and affects criterion A function 10 years later. Identity diffusion increases normatively, just like traits do in adolescence. It also tracks with personality pathology. So identity diffusion is a core feature of personality pathology. It shows that normative decline. This is a healthy sample. We did not look at whether there were kids that get stuck. I think if we reanalyze, we'd be able to identify the group that gets stuck, just like we did for traits. Maladaptive identity increments general functioning in predicting personality pathology. This is important because people have started getting confused with what that personality functioning means general functioning, like just how you do in your work and how you do in your job and in your general disabilities functioning. So we showed that identity gives you something different over and above general functioning. Same with general psychiatric severity. People started saying, well, criterion A is just general psychiatric severity. It's just the P factor. So we did this in a regression analysis, and we showed that maladaptive identity diffusion increments general psychiatric severity in predicting personality pathology. We started doing a lot of narrative identity work in order to show that it correlates with personality pathology in adolescents. Also that it associates with attachment security and mentalizing. If you remember the model, we need to be able to show that attachment security correlates with narrative identity and that mentalizing plays a role in building that narrative identity. We also showed that the agentic aspects of narrative identity seem to be particularly important for personality functioning. There are multiple ways that you can measure narrative identity, and it looks like agency, this building of self, a sense of self, as someone that can affect the world, not just that the world is happening to me, seems to be very important for building narrative identity. We've done a lot of work on identity diffusion measures. This is the ADA, Assessment of Identity Development in Adolescents. This is the Level of Personality Functioning questionnaire in 12 to 18-year-olds. These measures do really well in identifying young people with personality disorder. We've also validated the Awareness of Narrative Identity questionnaire. Coding narrative identity is very time consuming, so having a self-report measure that can get more or less at the same features is important, and this work. We've also shown that identity diffusion increases personality disorder pathology, which increases suicide severity. Just acknowledging that then identity disturbance is really important. In this study, Jessica Peterson's reanalyzed 2 adult samples, very large adult samples, and our adolescent Menninger sample, and showed that identity disturbance is a central symptom across age groups. And all of this research together has led me now in 2019 and 2020 to begin saying that self is the nexus of personality dysfunction. I'm not the first person to say this. Otto Kernberg has always put emphasis on identity function. Livesley, Don Livesley has always put self at the center of personality dysfunction. It's just that we are coming back to this idea now with a developmental focus and with more empirical data. So where are we going briefly? 3 important directions in my view. First of all, we need to move to a dimensional model. This is a special issue that Josh Miller and I did in Personality Disorder Theory, Research and Treatment, the APA Journal for Personality Disorders. And we put together all the evidence base for the alternative model. So if you want to go look at that, it's published in 2022. I've got all the papers if you want me to send it to you. This is our editorial, just saying that there is now enough data for the alternative model to move into section 2. We just have to go forward and do this for all of the reasons I said. It's developmentally appropriate, it's destigmatizing, and all of the data now shows that it's a better empirical foundation than the 10 categories, which most, apart from BPD, the rest of the disorders have very, very thin empirical data behind them. The second thing is we do need to go from description to action. This is a special issue I did with Andrew Channon and Maria-Luisa Cavalti in Current Psychology and Psychology, also published 2021, where we summarize all of the information. This is actually freely available. If you just go to Current Psychology Opinion 2021, and you Google this, you will find all of the papers saying that we have enough data on young people. We need to just start diagnosing, assessing, and treating personality disorder in young people. In there, you'll see the barriers to care for adolescents with personality disorder that still prevails. Andrew Channon talks about 5 failures and 5 challenges for prevention and early intervention, which all comes down to just we need to go over to action in this. We have to encourage clinicians to do this for prevention and early intervention. And then finally, clinical staging and generalist approaches. So if we do take this model that I've been talking about, you can use a clinical staging model, AMPD, alternative model, or ICD-11 informed clinical staging model for lifestyle and personality pathology. And we've published 3 papers on this already. If you are interested, I can send you it. What clinical staging means is that we look at the development of a disorder, and we start intervening at earlier phases of the disorder. So going by the model, you can do at early stages of the disorder, you can begin to treat internalizing and externalizing problems. When the disorder during adolescence begin to onset, you need to assess traits, maladaptive traits, and you need to assess level of personality functioning. As the disorder then begins to progress and be at a 3 or a 4 level, you need to also measure functioning. And then there are interventions that you can do at each stage of the disorder in order to have a more comprehensive sort of 360 approach to prevention and early intervention and treatment for personality disorder. Coming back to common factors, Amelia briefly talked about this. If we are going to think about personality pathology as a common factor that cuts across all personality, we need to our treatment needs to focus on the common factor. And as we saw, mentalization is what builds the personality. When a person has personality disorder, we have to re-enhance mentalizing capacity, because mentalizing capacity is broken in people with personality pathology. They cannot do the work of reflecting on other people's minds and self in order to have an integrated sense of self in the context of interpersonal relationships. So in this book, we really try to explain mentalizing in very simple terms. We wrote it really for our students and people, frontline clinicians that don't have master's or PhD level education, to understand mentalizing and to start using mentalizing in any psychotherapeutic modality. It's not an MBT book, this book. It's a book to help people understand how to incorporate mentalizing in all psychotherapy. In fact, we make the argument in all relationships. Relationships with your partner, relationships with your child, relationships with your coworker. There's also these generalist approaches that provide you a framework for clinical staging. Lois Joy Kane and I did a book for adolescents, Good Psychiatric Management for Adolescents. You'll see it's written as personality, a borderline personality disorder, but it could just as well be for level of personality functioning. And then it's built off of John Gunnarson's work that Lois did with him for adults. Andrew Channon has been doing the same kind of work, showing that generalist approaches are as effective as some of these specialized, expensive approaches like DBT and MBT. And US Hitsebaut in the Netherlands have been making the same point, that we can, for very ill people at a level 3 or 4, where the progression of the disease through the clinical staging has reached the final level. Of course, you can do MBT and DBT, and you need to do MBT and DBT. But at earlier phases of that clinical staging, you can do more of these generalist approaches. These are all of the people that I work with and that has contributed to this research, for whom I'm grateful, including some of my students. And that is the end for me.